In terms of patient selection, we recommend LAL for eyes that would have only qualified for a monofocal or monofocal toric lens implant, and LAL Plus for those who would have qualified for a multifocal or EDOF lens. Here are some suggestions and helpful tips to aid in your surgical implementation of the LAL. Visualize the lens cartridge and injector and ensure that the cartridge is locked into the injector. You may need to enlarge your corneal incision to the recommended 2.8 millimeters if you routinely use a smaller incision. Make sure that the anterior chamber is well filled and pressurized with OVD. Check the trailing haptic to make sure that it is externalized and not being compressed by the injector's plunger. The optic body should be visible in the window of the cartridge. Go into the eye far enough that the notch in the cartridge is past the edge of the rhexis. Watch the leading haptic as you begin to advance. Go into the eye with the cartridge bevel down and rotate your wrist as needed to properly orient the LAL. Gently guide the leading haptic into the capsular bag equator so that it is properly positioned. Once most of the optic has been delivered, you may notice that it unfolds more quickly than an acrylic lens. Retract the center rod once the optic has been delivered, and then begin to advance it again to deliver the trailing haptic into the proper position. At the conclusion of surgery, be sure that there is a plan in place for saving and transferring the QR code for your patient's LAL in your records. This will be utilized to add each eye to your LDD and easily access the patient's records at each light adjustment or lock-in visit. Following surgery with LAL, patients should be allowed at least 17 days to heal in a normal fashion from cataract surgery. In my practice, I've found that beginning light adjustments at about 1 month postoperatively is enough time for most patients to be stabilized for an accurate refraction. It is recommended to follow your typical postoperative care protocols, including eye drops and follow-up visits. As with any lens implant surgery, some patients may experience dry eye and ocular surface disease after cataract removal and LAL placement. Ocular surface management is critical to success with LAL surgery. Beginning from the preoperative assessment, be sure to identify and address any signs or symptoms of ocular surface disease. Special care may be needed for patients with complex corneas, prior ocular surgery, or diagnosed dry eye disease. It is critical to success that refractive data is stable and reliable prior to proceeding with adjustments or lock-ins. At each light adjustment visit, patients should be evaluated with distance and near vision, monocularly and binocularly, a manifest refraction, and a subjective assessment of their lifestyle needs and visual satisfaction. A thorough anterior segment is critical, including lids and ocular surface. Ensure that the patient's demographic data is accurately input into the LDD for each eye, along with the correct LAL serial number, dioptric power, and current manifest refraction. Light adjustments can be utilized to treat from -2 to +2 diopters of spherical refractive error and between 1/2 to 2 diopters of cylinder in quarter diopter steps. During a light adjustment treatment, it is imperative to have access to accurate pre- and post-operative data for each eye. Remember that the implant has no inherent toricity, so astigmatism is largely uncorrected until light adjustments begin. Patients may need some reassurance as they may notice that their vision is not crystal clear in the early stages of recovery prior to adjustments that will correct the refractive error. To prepare for a light adjustment, some patients may need more than one dilation drop. Adequate dilation is critical for a successful light delivery treatment. Once a treatment plan is selected, make sure that both lens haptics are visible before attempting to begin the treatment. Patients who are more light sensitive may need an extra numbing drop and lubrication to comfortably complete a light adjustment. Maintaining proper alignment through a well-dilated pupil is key to achieving the most effective adjustments and lock-ins. We can also advise patients that rose-tinted vision or erythropsia can occur following treatments but will resolve. Visual improvement is expected approximately 48 hours following an adjustment, so in my practice, I schedule the next adjustment approximately 1 week later. This allows enough time for the patient to experience their vision after the adjustment. If the patient or doctor feels that more time is needed to make treatment decisions, adjustments can always be deferred. If patients are uncertain about their visual goals, trials with loose lenses or trial frames in the office may be useful to simulate different visual scenarios. While vision in trial frames is not an exact simulation, patients may be able to adapt or understand what they desire. To achieve full polymerization of the macromers, at least one refractive adjustment is required. If dilation is poor at the second lock-in treatment, the nomogram may recommend a third lock-in for completion. When you've finished all adjustments and lock-ins, congratulate your patient on the completion of their LAL journey.